the organs at risk and PTV contouring is the next step. For our department, we decided to do a breast hold setup since, I don't know, more than 10 years. And we stick to that because the workflow has been highly accepted by the staff and also for the patients after training of the inspirational breast hold. We are using the ABC system of Electa, but sometimes for patients who do that tolerate the snorkel, we also use the Catalyst system with surface tracking. We always administer IV contrast, use a slice thickness of maximum 3 millimeter. And of course, the breast hold has to be coordinated with the contrast phase. So for the metastasis, we take the portal venous phase, and for the HCCs, the late venous phase, because the early arterial phase is quite difficult to catch so fast with the ABC in combination. So then we match with the diagnostic MRI with either rigid or a deformable match. So if it's possible, we have the software of Velocity, and then we can also do a deformable match if the rigid match is not good enough. And then we contour the PTV, where we try to consider all available imaging modalities. So we match, and if we have a PET or if we have an ultrasound, we try to consider everything. For some entities, we add CTV margin and then a PTV margin with 9 millimeter craniocaudal and 5 millimeter radial, to account for the residual motion for during SBRT. And for the organs at risk is, of course, especially important to take care of the serial organs in the upper abdomen. So for the small bowel, stomach, esophagus, but also for the heart, the coronary arteries, and the central hepatobiliary structures and the chest wall. So, for example, this case it was a case where we didn't, because of the anatomic proximity of the duodenum, it was not possible to deliver really aggressive, highly aggressive dose. So we could only apply here 35 grays. And especially for those cases, it's really very important and not to forget to contour those structures. There's a very nice case study to learn why is it important if we forget to contour these structures. We had also at the very beginning, where there were not published constraints for these serial structures for the SBRT situation. So in 2006, 2007, we also had a patient with a gastric bleeding 2 years after SBRT of the liver, and a similar case was published here. It was a lung SBRT with a re-SBRT with not really correctly prescribing the stomach, and that's what the patient then happened with the patient. So he developed a deep ulcer, and for the second course of SBRT, and a fistula, which of course could not really be treated. So that's why the serial structures are really important for those cases. For central tumors, we always contour the central hepatobiliary structure. So we use the Stanford protocol for that. So we contour the vena porti and just blow up the structures with 5 millimeter margins. And this is for our DIBH setup enough. And for the Stanford protocol, they took a margin from vena porti of 1 centimeter and prescribe also this structure as suggested by the Stanford people. And for such tumors and the periphery near to the thoracic wall and ribs, we also contour the ribs, but not only the ribs, but also the intercostal spaces, because the intercostal nerves, which cause this thoracic wall syndrome after SBRT, are the most important structure to protect. So we do this C form like contouring up the thoracic wall. Yes, so there's an interesting study of Professor Gicker from Würzburg, also from Germany, also in the framework of the German Stereotactic Society, where she was just sending out some data sets on diverse clinics and with different contrast enhancement phases, and just looked at how different the contours are, so some kind of interviews contouring differences, and for the because there is no really gold standard of GTV delineation and treatment of HCC. There were the first two cases where you see that the contours have a quite good agreement, but the third one, also with vein infiltration, had a quite catastrophic result also among experts. So they were all senior radiation oncologists who contoured this case. So we see that it's not that easy to do a good PTV for HCC, especially in cirrhotic patients. Okay, so at the meantime, what do we do in Mannheim? If it's possible, we apply 60 gray in 5 fractions for tumors which are smaller than 5 centimeters and not central. If the small bowel or duodenum directly surrounds the PTV, then we apply similar protocols as pancreas SBRT. So 35 to 40 grays in 5 fractions with an individualized dose. So we try to put as much dose as we can in the GTV, but do not violate the organs at risk constraints. And we prescribe hot, so 95% of the PTV with a Dmax of 150%. And sometimes we decide against this hot prescription and prescribe to the median if we are afraid that any moving serial risk organs such as stomach or duodenum or small bowel could get into the PTV during radiation. So the next step, how should we report? How should we document? That's also an issue. If you want to read this ICRU report, it's quite strenuous, but these nice guys just summarized it. So it's much easier to read in the German Radiation Oncology Journal. We should report the DVHs, the PTV dose to 98% and the 2% of the PTV, or if it's smaller than this dose, near min and near max dose, and the organ risk doses and dose homogeneity. So we also try to get used to this, and for the plan documentation, try to catch consequently these parameters since then. Okay, so what kind of image guidance can you do? Of course, if anybody has an MR-Linac, then it's fine. For poor people like me, we are still using daily IGRT with breath-hold cone beam CT, which of course for the liver is kind of suboptimal. We used a very long time an additional ultrasound-based tracking system from Elekta, but however, it was only an experimental system. So everybody for his own department has to discuss which method is the most convenient for their own workflow. So we can discuss fiducial, especially in the left lobe or caudally, where the liver is very deformable, depending on gastric or colon filling. If there are some post-op clips, which is very often the case, then you can use them too. And if it's possible, I think it's also nice to have any additional monitoring of the breath hold. So, for example, ultrasound if it's available, or surface-based tracking. So we looked at how the intrafractional and inter-breath hold reproducibility is for these patients, and we so this is what you see, this additional ultrasound system we have used for that. That's an experimental version of the Clarity system of Elekta, which is used for prostate patients, but this subversion can be also used for liver. And this is, for example, a liver met, which we tracked directly with this system. And then we compared the data which we won with the ultrasound during each press hold. So we were doing the cone beam CT and parallelly at the same time the ultrasound imaging, and just looked at how much residual motion do the patients have. And this may look large, but these are in millimeter range. So you see that we compared the motion to the projections of the diaphragm dome from each kV cone beam CT projection. And we saw that the ultrasound correlates fine to the diaphragm motion, and that the breath holds are quite stable. So the 95% of all patients have shown less than 5 millimeter residual motion during the whole series and overall fractions, which probably indicates that the treatment margins we are using in the meantime are enough to compensate this residual motion. However, we have also seen that there are some patients who have larger motions or changing motion patterns from fraction to fraction. And for those patients, we should really think about for the future for individualized margins or adaptive treatments. So this paper is from Heidelberg, where they examined if it's possible to use surface guidance for position verification and monitoring and for breath hold. And they have already also indicated that the surface guidance shows quite large interfractional variability, especially for liver patients. And this work is not published yet. We plan to submit it now to the Green Journal. We did a similar data set for patients where we examined for the same time with the cone beam, ultrasound, and the surface scanning system. And what we have seen that the AP motion correlates fine, so that the surface scanning system is probably a good surrogate for that. But however, the CC motion was not always correlating with the surface motion. And probably the AP motion was also overestimated by the surface scanning system. So probably direct soft tissue based monitoring like ultrasound or MR-Linac is probably more suitable for intrafractional monitoring than surface scanning only. But I think surface scanning based monitoring is, however, better than nothing. So large errors can be noticed with surface scanning intrafractionally. Okay, next step planning. We in Mannheim do mostly a VMAT plan, so not really a big issue. You can also use DCAT as shown. We tried to use non-coplanar fields, however, with the ultrasound setup, it was not really useful because we couldn't do a large enough non-coplanar angle. So in the meantime, we are treating with VMAT. So what are the dose tolerances? I think that's my favorite paper, which is a very nice help for everybody who begins with SBRT. It's a very good summary of each body region, not only liver, and all constraints for each organ are published there. Before that, there were several papers in the seminars of radiation oncology, for example, for small bowel dose, where they publish for the different fractionation schedules, low dose and low risk and high risk limits. We tried to stick to the low risk limits with the Dmax, the point Dmax doses for 5 fractions, for example, for small bowel of 29 gray for 5 fractions. The same for chest wall, but however, with the chest wall toxicity, you won't kill the patient. So we really stick to the constraints where regarding serial organs, so for stomach, for duodenum, for small bowel, but for the chest wall, we sometimes do not stick with that and talk with the patient about it, and then we do an individualized compromise. So I think I can skip that. And yeah, that's the liver tolerance. It's a recent paper from Laura Dawson, where the radiation dose effects for the liver were published in our own cohort. So in the Mannheim cohort, we didn't see until now radiation-induced liver disease. Thanks God. So it was not relevant. Mostly the constraints for the serial organs, which are difficult to fulfill in some cases. Okay, so this is the central liver toxicity, which was also published first, the first case report in 2015. So those constraints regarding the bile ducts and it was very an impressive study, and that's where the central hepatic structure contouring is coming from, which I mentioned just a few minutes ago. And there are some nice papers who publish where some dosimetric predictive factors for hepatobiliary toxicity has been published, which you can use for the 5 fraction schedule. And there is also a predictive tool, even a nomogram, where you can put some data from the patient, for example, the ALBI score, and then you get the probability for central liver toxicity, and then can adjust the dose. What should we do with the gallbladder? I still don't know a better paper than this one, so nobody really knows what to do with the gallbladder as an organ is it an organ of risk or not? So this is a paper about more than 90 patients, and they describe the case with cholecystitis and gallbladder perforations. So especially on this image, developed a grade 4 cholecystitis with perforation, but they write in the conclusion that they still do not have any constraints, and they themselves don't prescribe the gallbladder. So myself, I didn't see any gallbladder toxicity until now. I try to avoid hotspots in there, but I think that's a point where nobody knows how it should be prescribed. Okay, liver tolerance. I think everybody knows that the liver is a parallel organ, and that the difference for 1,000 and so that the volume should be saved. So 15 gray should be avoided for a larger volume, and the liver can still regenerate, and the metastatic tumors have, of course, a better tolerances as the primary ones. And the liver reaction can be very nicely seen in the post-SBRT follow-up. So this paper is very old. Already the pioneers of the liver SBRT from Heidelberg have described this post-SBRT phenomena where the healthy liver reacts after irradiation. These are called from the outer hair fat reactions. And this you can also see histologically and macroscopically. So this patient was treated with an SBRT and afterwards operated on a second MET. And here you see the region where he was irradiated for the first time. And this corresponds to a veno-occlusive disease without radiation-induced liver disease. This is also what our radiologists should know, and it is important to recognize these typical imaging findings because it's often diagnosed as a progress from unexperienced radiologists. So it's also important to share it interdisciplinary. So that's what we also looked at in the post-SBRT MRIs and found quite similar reactions corresponding to the isodose lines. Always not without any clinical symptoms, but however, very impressively in the post-SBRT imaging. And now we have some also unpublished data how these reactions, peritumoral reactions, develop after a long time post-SBRT. So it was a pre-planning MRI, and that was the reactions 3 months post-SBRT. And as you see, as time goes along, then this reaction disappears. So the liver just regenerates, and 4 years after SBRT, no reaction is seen anymore. So it's it's a transient reaction of the liver of radiation, which then regenerates with the time. You can also, of course, use this reaction. If we already have it, we can also use it. So we can look at if we met the target. So it's a clear clear sign. If, for example, if this reaction is not there where the metastasis was, then something was not okay with the motion management. And based on this reaction, we also did a paper where we try to estimate as an in vivo accuracy analysis how accurate the treatment delivery has been. Okay, so as I mentioned, we didn't really see any clinical toxicity except of this gastric bleeding. The metabolic toxicity has been published by this group. So they published the transaminase elevation and albumin reduction, mostly smaller than grade 2. And this was associated with doses to 700 cubic of healthy liver. And that's quite the same which we see also in our population. So that these are also unpublished data. But as I said, nobody developed classical or non-classic RILD, but we had also seen an albumin. Gamma. Okay. So I think we come to the end. Special situations is it possible to do a re-SBRT, an infield or outfield re-SBRT? I think outfield in liver re-SBRT is absolutely no problem. We did it also several times. I think it is interesting if it's a real infield or partly infield. So it's again from the Würzburg group where Eleni Gika looked at the repeated SBRT series. She didn't see any excess toxicity or no parenchyma necrosis. However, it should be a careful patient selection, and there should be no overlap with stomach, bowel, or central hepatobiliary structures, and can be used. Infield re-SBRT can be used if there are no other local ablative options are open, but there are no prospective trial data on that. We in Mannheim did one patient with a completely full infield re-SBRT. She tolerated it fine, and we also didn't see any excess toxicity in spite of full dose also in the second series. So this is an Asian series also with repeated SBRT, not only infield, and they had very nice high local control rates for the repeated series, satisfactory overall survival appropriate for this cohort. And they also say that the patient selection is very important. So patients should have a good liver function, good performance status, and if possible, small tumors. So I think that was what I wanted to say, and then now we can go over to the discussion. And thank you very much for the invitation and the friendship and the good collegial communication always. And
thank you, ma'am. Thank you for a nice, detailed session today on SBRT. Thank you very much.